Our next surgery. Give me an, let me see, shot. This is going to be a cervical Deuk laser disc repair for a patient with herniated discs in his neck, AP. He has two disc herniations, C5-C6 and C6-C7. And we're going to be navigating, okay, so I'm a little bit too much to my side, which is fine. We'll just reposition to the middle. Shot. That's better. Lateral. So we use x-ray machines to localize and navigate. Localize means figure out where we're supposed to be, and navigate means to go from the outside of the body to the inside. Shot. And to navigate through the inside of the body to where we're supposed to go. Believe it or not, the glove is not, the needle is not behind my glove. It just looks that way. But, shot. We are inside the disc. That's 2, 3, 4, 5, 6, 7. Everyone agree? 6, 7. All right. Let's get an AP. No, Coker. Watch his elbow, please. So to do this Deuk laser disc repair procedure, which replaces fusion and artificial discs, we start by using a spinal needle and entering the disc that's being treated through the front, passing through the annulus, not damaging it, but spreading it. As you can see, the needle is at the top, 2, 3, 4, 5, 6, 7. The needle is at C6-7. On the AP view, it looks perfect. On the lateral view, it looks perfect. And now we're going to inject a little bit of our dye. Once again, we don't have the Omnipaque, which is the iodinated dye, because there's a national backlog in the United States. It's, in my opinion, fake, but it allows them to say they don't have enough, and they raise the prices tenfold. So we have to pay 10 times what we normally pay for the dye. But then, of course, they can't tell everyone that the dye is in short supply and then supply it, right? Because then it wouldn't be in short supply. So they have to fake these shortages of medications so they could justify a tenfold increase in price. And they get to stockpile it and gradually bring it back on the market. And that's what's been happening for years under the FDA. The FDA has allowed it to happen. It's criminal because it affects medical supplies. All right, we're making a 4mm incision. And that's how big the incision is for the Deuk laser disc repair with the cervical spine. Cervical spine is the part of the spine that shot is in the neck. So I'm going to take the guide wire out. Shot. That's it right there. Very good. When I say shot, what I'm actually doing is taking a picture with the x-ray machine. So don't be confused. Shot doesn't mean we're giving a shot to the patient. It just means we're taking a picture. It's an old terminology used in orthopedics and neurosurgery. Some people say picture, some people say shot. I grew up saying shot, so that's what I use. Shot. Shot. Dr. Patel, on the other hand, is always saying picture, picture, which sounds funny to me. Huh? Pick, pick. So Meta says pick, Patel says picture, and I say shot. You guys, I feel bad for you guys. You guys must be so confused. All right, for those of you watching, this is the patient's neck, by the way, and you can see that the instruments I'm using are going in on the right side of his neck. There, see, we're right in the dead center. The spinous process is right there in the middle. And I said this before, but if you kind of look down and get to the spine, which is deep past all these soft tissues, there's two muscles in the front of the spine called the longus colli, and there's a right longus colli and a left longus colli. You want your needle and dilator to be between the two longus colli. There's about a centimeter of space there, maybe a centimeter and a half, and that's the perfect place to be, entering your disc. I'm going through what's called the anterior longitudinal ligament, or ALL, and I can feel the fibers spreading. So I'm not making a hole. Somebody last surgery said, Dr. Deuk, what happens to the hole in the front of the disc? Well, there is no hole. It's literally pushing the fibers apart. You're not cutting anything and making a hole. You're just spreading. And this device called a dilator spreads things. That's what it does. And it doesn't damage anything, it just spreads it. So there really is no hole when we're done in the front of the disc. There is a hole in the back. And the hole in the back of the disc is from the herniation. It's not a hole that I create, it's a hole that was created by the patient during their traumatic injury. Okay, you can see we're in the back of the disc at this point. And we're going to verify again, 2, 3, 4, 5, 6, 7. So I'm looking at the disc at the top. It's the C2. It's a tall one. And then a space, and then the number 3 bone. Sorry, C2 bone, 3 bone, 4 bone, 5 bone, 6 bone. Let's show our audience the number 2 bone. Jordan. Jordan will use a little white arrow and show you the number 2 bone. It's up there. Then show them the 3 bone, and 4, so on, 5, 6, 7. So we are between the 6 and 7 bones, and that makes this the 6-7 disc. Now last time I made my incision 5 millimeters. Today I made it 4 millimeters. Or this case I made it 4 millimeters. So we're right on the dot of 4 millimeters. Shot? You're pulsing, right?
Yes, sir.
All right. Within a few weeks, the patient won't even see the incision. It'll be gone. It'll be completely healed. The whole surgery, 2 discs are being fixed with this tiny little cut. You can see the dilator has moved back a little bit. Now it moved back a bit, quite a bit. Usually to me that indicates that the disc is under pressure, shot. And the pressure it's under is from, shot, inflammation. This is an inflammatory condition. Herniated discs are inflammatory disease. It's an inflammation in the back of the disc, specifically the posterior annulus. That's where all the symptoms come from, shot. So because the dilator keeps pushing back in, shot, I'm having to stop and reposition it because I don't want to do a biopsy of the disc. I want to, shot. Is that it? I want to basically advance the tube over the dilator. I don't want to bring the tube down. You have to have the dilator there. If you don't, you're just going to end up biopsying the disc. You don't want to biopsy the disc. Shot? You want to remove the herniation. You don't want to take the middle of the disc out. There are some procedures that used to be done a long time ago, shot, where surgeons would remove parts of the disc, and it was called an IDET, intradiscal electrothermoplasty, where they would heat up the middle of the disc and cook it and burn it so it shrinks. And then they would hope that the herniation sucks back in, which of course it really didn't. That's not what we do here. We're doing a real surgery, an endoscopic surgery. And to do that, we need the tube to be actually in the back of the disc where the herniation is. And that's where we are right now. So now I'm going to remove this dilator. And you can see the dilator. It has a tapered tip. Can you see that, Henry?
Yep.
So it really doesn't cut anything. It just spreads tissues. And now we're going to get ready to do the surgery. Let me just show you what we got here first. Can you all see this?
Yes.
So I was talking earlier about this patient's neck is beautiful. It's like the perfect neck for this kind of surgery. It just doesn't get any better. The patient's face is here. He's looking up. He has a tube in his mouth. That tube goes into his bronchi, and it's ventilating his lungs, okay? So he's getting a machine that's basically breathing for him. That's typical of general anesthesia. The chest is down here. We're on the right side. This is the Adam's apple right there. You can see it. so you get an idea of where we are for C6-7. It's at the base of the neck, the clavicle or collarbone here. He has a beautiful neck, nice anatomy. So we're going to do the whole surgery with this tiny little tube. Our patient is from Canada, as a matter of fact. Where's the fluid adapter? The patient has come from Vancouver. He lives there with his family. He's here with his daughter. She's going to be taking care of him. And they're going to be here till tomorrow. And they'll come in, they'll be here tomorrow after surgery to quick checkup. You better put it on my wrist. And then they head home. I think he may actually be staying a few extra days. Okay. Yeah. I think they're going to go visit Mickey Mouse. Let go, please. All right. Oh, here we go down the tube. There's the bottom of the tube and where the herniation is. All right. We're having a hard time visualizing, Luis. You see? The fibers need to be re-glued. Has this scope been in?
Oh yeah.
When?
Maybe a couple weeks.
Are you kidding me?
No.
You sent it in a couple of weeks ago?
Yeah.
And they repaired it?
No.
Huh?
Still repaired.
No, but it's not repaired. Who'd you send it to?
To INS.
Yeah, you got to send it back. It's not repaired. You understand how to tell if it's repaired or not? Should it be blurry like that? No.
No, of course not.
Yeah. So they actually glue, if it's in neutral and it's blurry, then they glued the fibers wrong. You understand?
I understand. Kristen, can you do me a favor? Can you, take a video of that, please? What he's doing and then please. Thank you. Because when I send an email, I send a video.
Yeah. Thank you, Luis.
Oh, one question.
He wants a video of that screen. He wants you to show how blurry it is. Okay? And then send it to him so that he can send it in. See how blurry it is?
Oh, yeah.
There. I have to bend it in order to get it clear. And you shouldn't have to do that. It should be clear and neutral. Very blurry. See that?
I see.
Yeah. So find out who repaired it. Talk to the technician, the head technician. But that's a problem. Do we have another scope available? All right, let's go ahead and show our audience why why herniated disc like this right here. You can see the tear right there. I'm working on it with a laser. Why do herniated discs cause neck pain? Why do they cause headaches? Why do they cause arm symptoms? It's all due to inflammation. Specifically, don't open it yet. Specifically, inflammation in the back of the disc, right where we are, in what's called the annular tear, posterior annular tear. And that's where we are right now.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. We're still working on this disc. This is the number 6-7, the bottom disc that we'll be fixing. And things are going well so far. We found the annular tear that you saw in the video is a source of pain and inflammation. Neck pain, headaches, arm pain. All the symptoms of a herniated disc come from inflammation. That's a herniation right there. You see how it popped out of that crack? That crack is basically the back of the disc, epidural space. So that's the foramen. That's where the herniation came out of. That was sitting right on the nerve out there. The foramen out there, right down below the laser. That area down here is the foramen, and that's where the herniation came out of. That's the left side. That's where he's having more of his symptoms, though he has bilateral symptoms. Now he has, just for note, he has 3 herniated discs in his neck. He's only fixing 2, and I think that's the nerve root down there. He's making the right choice. The third one I offered to do for him, but he wants to hold off, and I think it's fine. The third one is not causing much of his symptoms, in my opinion, but it is abnormal, and it is probably causing, if I had a best guess, 10% of the symptoms. I told him I don't have a crystal ball, but I think fixing these 2 is really going to get rid of the majority of his pain and symptoms. Now, he has an interesting set of symptoms. He's got not just tingling in his hands from the herniation, irritating inflammation on his spinal cord, but he also has it in his feet. And so we had a long talk about that ahead of time. And a lot of people have symptoms in their feet too, but I don't like people thinking that for sure it's coming from their neck, because there's a chance it's coming from their back, their lower back, you know? So you got to get an MRI of your lower back. You don't push this fiber against this. I don't know what he's doing with the fiber, Luis. You understand, in the lumbar spine you have to push towards me. In the cervical you don't, okay? I don't want to grab the fiber like this. I want it to be away from my finger. You need to control it. Yeah, you need to talk to him, Luis, and get him to do it right, okay? I can't stop on my conversation with the observers just to tell him what he has to be doing. I don't mind him doing it, but you got to be controlling that. All right, any questions from our audience?
We have 3. Well, the first one is a statement, and comes from Sandeep Barrage on YouTube. And he said, my wife has a C5-C6 protrusion, 12 weeks into it, and not getting better. We're in the UK, and we'll come over to the US if needed.
You need to. So Sandeep is his first name?
Sandeep, yeah.
Hello, Sandeep. The UK does not have this surgery. The endoscopic spine surgery of the cervical spine is extremely rare to find a surgeon in the world that can do it. And the Koreans do it, but they don't do what I do. They only treat the arm symptom, the pain in the arm, the weakness, numbness in the arm, from a herniated disc pinching the nerve. We go beyond that with this technique called the Deuk laser disc repair. The Koreans don't know how to do the Deuk laser disc repair. So the Deuk laser disc repair has the added benefit of repairing the annular tear to allow it to heal properly so the problem doesn't come back. That's what I'm doing right now. This is not pressing on the nerve right here. You can see it's away from the nerve. But if I don't clean this up, and this is called an annular debridement, if I don't do this, then this disc won't heal properly, and the patient will come back for another procedure, another surgery, because their disc never healed. So only our surgery here in the United States does an annular debridement to heal the disc, allow the disc to heal properly. So I would encourage you to come. We have a lot of people from England that come here to the United States. The good news is we're on the East Coast, so we're close to England. You know, you'll have to come over and go south a little bit, but it's worth it. There's nobody in Europe that does this surgery. You're watching the only surgeon probably in the world that does it this way. Now, there are surgeons that watch my surgeries and try to do what I do, but it takes a lot of training, and I've not trained anyone that's over in Europe or anywhere else in India or anywhere else in the state. So we look forward to helping her. All right, what's the next question? I think that's the last herniation. Everything else looks clean.
Next question comes from Jerome Fryer on Facebook.
Oh, Jerome. Hello, Jerome. Yes, this is your patient, Jerome. I know. Jerome is in Canada. This patient told me he went to your office and saw you.
Oh, wow.
Nice to hear from you, Jerome. Jerome is a chiropractor in Canada, but more than that, he's actually like me. He's passionate about spine and advancement of spine care and getting people the very best care they can possibly get. So yeah, the patient and I, this one having surgery, was talking about how he was in Jerome's clinic just last week, seeing Jerome. Hope all is well. Did you have a question?
Yes, his question was, what are the patient's symptoms?
What are the patient's symptoms? All right, well, the truth is I don't have them all written down. What I remember is he's having neck pain, numbness and tingling in his hands, numbness and tingling in his feet. Left bicep weakness. So he's got weakness, he's got numbness and tingling, and he's got some pain. I think he even has some headaches, some cervicogenic headaches. So anyway, great question.
Next question comes from Reiko Pilot on YouTube.
What is it?
Reiko.
Yeah, that's fine.
It comes from Reiko Pilot on YouTube.
Yeah, I heard you.
Yes, sorry. And he said, what is the flat multi-sided blue surface we see in this video further down below the herniations being lasered?
Are you talking about the blue tube at 12 o'clock? That's the laser fiber.
I believe so, yes.
Yeah, the thing at 12 o'clock is the laser fiber. And the glass thing coming out, well, the blue is a plastic covering, and the glass coming out at the end is the laser fiber itself. All right, I think we're done here. Let me look the other way. What's the next question?
No further questions.
All right. Just about. A lot of scar tissue, by the way. That's what I've been working on for a while. A little calcified scar tissue. I just want to make sure we get rid of as much of this stuff as we can. There's a little bit left there, and we'll be done. Come on. You got to be ready to go. Just clean this last bit up and we're done here. This is a great time to ask questions. Also, if you haven't seen our app, we have a Deuk Spine Institute app on iPhone and Android. You can download it. It's free. We don't charge. We also have a free MRI review service where we could look at someone's MRI and let them know what we would recommend treatment-wise, see if you're a candidate for the laser surgery we're doing. No more herniations. You can see everything is gone. There's a little bit of foraminal ligament And you can see the dura and the nerve right down there, the blue thing. All right.
Lights on, please. Go off. Thank you.
Light on. We're going to put in some antiseptic, which is betadine. And then we're going, I need a light on. Then we're going to reposition this tube to the next level. So I just put in some betadine and we're going to irrigate it out. How is our patient doing? Doing well. Good. 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 All right. Once again, you can you see this here, Henry?
Yep.
Little pieces of herniation that have floated out. That's the irrigation, the cold irrigation that floats them out. We're going to bring our fluoroscope back in. We're going to get a lateral view and we're going to move the tube and dilator to the next disc up. I like to start with the hardest disc to do, typically the bottom disc or the top disc. And then I like to get to the easier ones. I don't know why, but that's the skier in me, right? You're way overexposed. So what does that mean? Well, if you ever ski the mountains, you know that at the beginning of the run is the hardest terrain. And as you go down the mountain, it gets easier. I don't know why I thought about skiing, but I think it's because our patient's from Vancouver. And Vancouver is close to one of my favorite ski resorts, which is Whistler. Shot? Yeah. And if you've ever been to Whistler, you know what I'm talking about. Beautiful, beautiful place in Canada. Whistler Blackcomb. We used to have a spine meeting there every year. And it was my favorite meeting because there's one spine surgeon who ran it, and he believed in an open, truthful dialogue. As a matter of fact, he's a big part of the inspiration. Oh, sorry. I shouldn't have. Yeah, here. He's a big part of my inspiration to do what I do now, which is the broadcast and live stream shot, so I can tell people exactly the truth about spine surgery and spine care. And he used to have basically the implant companies were there and surgeons were there, and they would share their experiences. The surgeons would, all the problems they had with the implants. For example, this was back in 2002 when artificial discs were being FDA approved and starting to come out, and the big companies were trying to say, well, they're better than a fusion, and a lot of surgeons who were using artificial discs at the time were having complications from them. And they were coming to the meeting and talking about their complications in front of the companies that sold the discs. And of course, the companies that sold the discs, they don't want that getting out, right? They want everyone believing there's nothing wrong with artificial discs, they're perfect, they never have complications. So the fact that the director of the meeting in Whistler would allow everyone to speak freely and tell the truth was really nice to see, because it was an open dialogue. Is there an esophageal probe? Because I don't see one. Stay there. Eric, not Eric, Jordan. Is there an esophageal probe? Can we pop one in? Shot? All right, that's perfect. Let's go to a lateral view. So once again, we finished with number 6-7. We're moving to 5-6. And I need to reposition. What are you doing? Don't put your hands there. If you ever want to do anything, get a snap and pull it down, but don't use your hand. 2, 3, 4, 5, 6. Shot. Shot. All right, need to find out which side of the spine we're on, because we're clearly on one side. Give me an AP. Wonder if I've gone too far to the left. Quick AP. Nope. It's actually pretty good. Hold on. Just let me move it a little bit back. I went a little too much to the left. Shot. That's better. Lateral. So I'm holding this up against the spine. This allows us to do more than one disc of surgery. I could use a different technique as well, but this technique seems to work quite well. Shot. Shot. Yeah, I am going to do one more AP. That's beautiful. 2, 3, 4, 5, 6. This is supposed to be pointing down, but that's fine. Shot. It's a quick AP. That's perfect. Lateral. All right, so we're exactly where we want to be on the front, back, and the side views. And what I'm manipulating is the tip of the dilator. Shot. Now once again, we're not making a hole. Somebody said, how do you fix the hole in the front of the disc? That's not a hole. We're spreading the tissues. So spreading is not the same thing as excavating. We are going to do another discogram. I want to stain this disc blue. Shot. 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 All right, good. We just cleaned out the hole in the middle. All right. Okay, so we are, everyone agree, 5, 6, 2, 3, 4, 5, 6. Shot. And we're supposed to be doing 5, 6, and 6, 7. You're not extending them, are you? Good. Shot. So we're in great position with the dilator tip at the back of the disc, right where the tear is. Now I'm going to bring our tube down. Can you all see this?
Yeah.
The entire surgery is done through this tube. It's 4 millimeters wide. This is as minimally invasive as spine surgery gets. Shot? There is nothing less invasive, except needle procedures, which aren't surgery. They're just needle procedures. They don't really work to fix these problems. But if you want to fix a disc problem, you need to do a surgery on the disc. And this is the least invasive surgery in the world. And it's only done here at Deuk Spine in Florida. Shot? Again, we're getting some pressure, back pressure from the disc itself because it's so inflamed. Shot? Looks good. Shot? Feel it going in. Again, the dilator's coming back. We don't want that. We just let it come back a little bit. That's fine. As long as I still have the shaft to work with. At this point, I don't want to go any further because we'll be biopsying. We don't want to biopsy of the disc. We want to remove the herniation, and we want to shot debride the annular tear. How's our patient? Shot? Doing good? No, I think I'm okay. I need another millimeter, and we're good. Shot? Pay attention to what's happening, okay, Oscar?
Yes, sir.
You'll know what to do if you pay attention. The best scrub techs always pay attention. They know what the next step is. Shot? Shot? All right, that's about as good as we're going to get it right now. Is he completely chemically paralyzed? Because I feel some tightening of the muscles. It seems a little hard to get to the back of the disc. Looks like he has some twitches. How many twitches does he have? I think we're okay. No, we're in as far as we need. It would have been good to have 0 when I was doing that, but that's when you want to make sure right when I'm starting, okay? So I could tell the muscles were tightening up. I could feel the disc collapsing and compressing. And sure enough, we tested the twitches, and when somebody is completely chemically paralyzed with neuromuscular blockade, they have 0 twitches. And actually, it goes even beyond 0 because there are times that we have 0 twitches with the monitor for the anesthesiologist, but I'll actually see direct stimulation of the muscle causes the muscles to contract. So we need really beyond zero twitches to get complete muscular relaxation. At this point though in the surgery we're fine. All right, little pieces of disc material in the tube. Any questions for me?
No current questions.
So this patient didn't have the Deuk laser disc repair as a choice. He would be perhaps a candidate for anterior cervical discectomy and fusion, which is a fusion surgery. It's the most common surgery done in the world for herniated discs or degenerated discs. This surgery you're watching now will replace it someday, worldwide, just not today. But we're trying to get that changed. Let's show our audience what an ACDF surgery looks like compared to the Deuk laser disc repair so they can see a difference.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least...
All right, we brought you back early because we just pulled out a good-sized herniation. Yeah, Luis, nice job. All right, so Luis has got the ticker tape there. We can actually measure this thing out. Check it out. It is like literally 5 millimeters. Okay, 5 millimeters. Doesn't seem like much, but when you're working in a space that's small, 5 millimeters is pretty big. All right, so any questions from our audience?
Yes, we have a question from Jerome Fryer on Facebook.
Hi, Jerome.
And his question is, would the twitches indicate a sensitive tissue?
No, the twitches don't indicate a sensitive tissue. What's happening is there's another herniation about the same size. I'm not going to stop the surgery for that one, but it's the same size. So what the twitches are is contraction of the muscle. Specifically the muscles in the neck, like the strap muscles, sternocleidomastoids, okay? So they're tensing up and contracting. But see, when somebody is under general anesthesia, we give them what's called a full neuromuscular blockade. What that means is we give them a medicine that goes to the neuromuscular junction where the nerve communicates with the skeletal muscle, and it literally shuts down the communication. So the muscles then are relaxed. It blocks whatever, you know, acetylcholine transmission or the action of acetylcholine at the neuromuscular junction. The point is that the muscles go silent. They basically go limp, which is what we need in order to ventilate the patient. So if the patient didn't have a neuromuscular blockade, then the anesthesiologist would say that it's really hard to push air into his lungs because his rib muscles, you know, and his diaphragm would be fighting the ventilator Okay, so we want full neuromuscular blockade so that we can properly ventilate the patient. Also, we don't want the patient getting off the table, right, during surgery. We don't want the patient jumping off the table. So to keep him from jumping and moving, we need to give him neuromuscular blockade. Okay? So when you start to see the twitches coming, it just means that the neuromuscular blockade is wearing off. And when I saw the twitches, I asked the anesthesiologist, how deep is the patient with his blockade? Is he 1 twitch, 2 twitch, 3 twitch, 4 twitch? And he was a 2 twitch. So he's, I don't know what that equates to, if it's 50% block, I guess. Point is, he was lightening up. We want him not so unblocked. Not yet. Now, when we wake the patient up and we want him to start breathing on his own, we've got to reverse him. And a lot of times we'll just reverse the patient. In time, the neuromuscular blockade will wear off on its own as the medication gets redistributed or metabolized, broken down by enzymes. But basically, that's all we were talking about. So the twitches is just expected, just indicating that skeletal muscle is back working. Something is keeping me from. Great question, by the way, Jerome. Great to hear from you, as always. By the way, Jerome Fryer makes spine models, and he makes the best spine models money can buy. He's out of Canada. I didn't even realize you were in Vancouver. Jerome, are you in Vancouver? Can you post your address for us on the chat so people can see how to get a hold of you to get one of your spine models? Go ahead and put a link to your website. We would love to see if anybody is interested in getting a hold of one of your models. I have a whole bunch of them. I mean, I've got tons because Jerome really has the very, very best. I mean, they are the Cadillac of models. We have a question, Jerome. How do you make the models? I think he takes people and just takes their spines out, right, Jerome, and uses their natural vertebrae and discs. Isn't that why they're so realistic? I'm just kidding, of course. But yeah, one of our nurses is asking, how do you make your models? I have them. If you want to see one, you can go see it. Yeah. They're the ones that are really... Okay. Jerome has also developed a tool that physicians are now using to measure how much pain a patient's in. It's a pain meter that he created and I tested out. And it allows the patient to squeeze a little, what do you call it? The little thing, like a little pressure. Okay, you got to get that stuff over a little quicker. And you can't move me so much. You're like pushing my hands around. So, a little cuff. How much time? 5 minutes. No problem, thanks. No, you can't 3D print the models. You should see. I mean, his models, you can squeeze the bones, and it literally squeezes the jelly, and the jelly comes out through the tear that I helped him design. Yeah. He's even got a Deuk spine model that I helped him design that has inflammation around the annular tear, so you can understand it properly. It's an inflammatory condition. So if you want the best spine models in the world, Jerome, put your address up. So we have a lot of doctors that watch these broadcasts and surgeons and pain management docs from around the world. I'm sure they would love to get a hold of a couple of your models. All right, just about done here. This is the last of the herniation over here. See if I can get any more out. Pretty much done. Good job, everyone. Lights on, scope off. So we fixed 2 discs today in this patient from Canada. Both of them needed to be done. You could see the tears were full spectrum, side to side, across the entire back of the disc. And I debrided the tears and removed the herniations. I'm sorry? Now we're going to take this out and I'm going to show you guys just how small of an incision this is. Okay? So we're going to take, just for those of you who haven't seen it, take this. Can you zoom in here for a second? I want to show them the size of this tube.
Yep.
Can you see this?
Yes.
Pretty cool, huh? Just sticking out of his spine like that. And now it's out. And again, the whole surgery is done in a... Why is the scope on? You guys are going to burn the fiber. Let's get that off, please. We're all done with the surgery. Let me show you the size of the incision so you can get an idea. I like to hold pressure in case there's any veins that are bleeding. This is a relatively bloodless surgery. We might lose 1 or 2 cc's. It's like 20 drops of blood. There's no scar tissue. There's no trouble swallowing. There's no hoarseness. Look at that, guys. Can you see the incision right there? Can you see that, Henry?
Yep.
You know, can I have that millimeter thing again? I'm going to bring the tape measure in. It's going to blow you away how small this is. Can you all see can you see the tape measure right here? Let me bring it in. Can you see
Yes.
the tape measure?
Yeah, we see it.
Okay, there it is. It's literally not even a 4 millimeter incision. It's like 3 millimeters. Can you see that?
Yep.
Incredible. Endoscopic spine surgery is the future. Is our last patient ready to go?
Yes, sir.
All right. All right, listen, type up your questions for me. I'll be happy to answer them. I'm going to come over there and answer them for you face to face. And in the meantime, why don't you run one of our testimonials from a patient we did surgery on with the Deuk laser disc repair.
I think the laser is the best thing out there to help with this type of surgery. It's all legit. That's all I can say about it.
Dr. Deuk here at the Deuk Spine Institute. I'm with one of my patients who's traveled to us from Mississippi. And he came here for the Deuk laser disc repair to be done for a herniated disc on his neck. And he's now here today, just one day after surgery. How are you feeling today?
Feeling great. Feel like the weight of the world been lifted off my shoulders. Feels a lot less pain in my shoulder, no more tingling. Feels like my body's trying to recover back to normal. I think the surgery went very well, no problem whatsoever.
And you're just one day after surgery. Can you tell whether the neck pain is gone yet?
The neck pain is gone, and the pain throughout my shoulder, the tingling, everything is gone. A little soreness in my throat. My voice is a little harsh, but other than that, I feel great.
Awesome. Can you show us your incision? Oh wow, look at that. So you have a 4 millimeter incision. You can see that right here on the surgical footage of the endoscope. We actually, when you watch the video, you can see all the herniated discs back there. We were pulling them out one at a time. You had about 20 pieces. And then you can see the nerve root right there in the foramen. And there's no herniated discs anymore on the nerve root. We got them all out of there. I had to open up the posterior longitudinal ligament and get all those fragments of disc herniation out of the epidural space that were pushing on your nerve. And I got a good look at everything and it looked fantastic. So I think you're gonna do great. Did you consider having like a fusion surgery? Did anyone offer you fusion before?
Yes, I was offered fusion. I was told that was the only surgery that could be done. I started Googling. I come across the laser surgery and I decided to give it a try. And I don't regret it. I think it was the best decision I ever made for my age, and I think the outcome would be a lot more better in the future. And it was a great experience. It really was.
And you work with metal as your job, so you didn't want metal in your neck, on your spine.
No, I think the cold weather would have had an effect on it. I think it would have caused an adjacent effect, is what they call it. When you do the fusion, it make the disc below it or above it wear out. And I'm 34 years old, and if I live another 30 years, I just feel like it would cause significant problems. I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
This is Dr. Deuk. I'm here with one of my patients who underwent the Deuk laser disc repair on his neck just yesterday. How you feeling?
I'm feeling better, a lot better. Already, after years of chronic neck pain, I'm already feeling better within 24 hours.
So is the pain that you had when you came here, do you still have that pain?
Not that pain, it's just, I think, a little bit from the surgery itself, but it seems like a lot of the numbness and the tingling in my hands went away, and already starting to feel a lot better.
Now you had a fusion done before, not by me, and you can see the scar there. And then you had the laser surgery done yesterday. And how would you compare the two experiences?
Night and day. I actually, when I had the fusion, had to go back to the hospital with complications. It just took a long time to recover from that. So this was much, much better.
Now, your fusion on your neck was done by a pretty famous neurosurgeon, right?
Correct.
Even with him doing it, there were still issues.
Yes.
What kind of problems did you have with the fusion?
Well, I went there for the numbness in the hand and still the chronic pain that I've had for many, many years. And it seemed to take away the numbness in my hand, but the pain was still there. So I spent many, many years going to chiropractors. I've had injections, I've had massage therapy, physical therapy, and most of them gave a little bit of relief.
Did any of them get rid of your pain?
Not completely, no. Just kind of made it bearable.
And is your pain gone now?
It's certainly getting there. I'm thinking probably within a week it'll all be gone.
And your surgery was done, even though you had a metal plate in your neck from your prior fusion, we were able to work around the plate and get in there and fix those discs, especially the C3-4, which was, you can see a lot of herniated disc material in there that was causing most of your symptoms. So I'm happy you're doing so well. And you had it outpatient, so you didn't even have to go to the hospital.
Correct. Yeah. Left in about an hour and a half.
What are you going to do now that we fixed your neck?
Well, I'm going to take care of it for the prescribed 6 weeks, and then hopefully I can start getting back to a normal life, be able to get back to golf and things I like to do. Dr. Deuk and his processes here and everything's amazing. If you have a lot of chronic neck pain or back pain, I would highly suggest coming to him.
Awesome. All right, my friend. Congratulations. It is February 23rd, 2022, and I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March. And I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did a
he
lot
did
of
a
Googling.
lot of research, and we found Dr. Deuk to be a man of integrity. He films all of his surgeries, he puts many of them online, and you can see for yourself all the good work that he's doing, and that he really, really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
before
correct.
surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
All the way
Yeah,
up.
just the next day, right
You couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, two of them, C4-5, C5-6, and the herniations were literally sitting on the nerve, and we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the foramen where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny, and here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70
I
degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees, and
nice.
then they woke up to about 11 degrees.
Ah, so the cold front came in. We get those from time to time, and it gets cold around 60 degrees. But most of the time, it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery?
Dr. Deuk will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So go for it.
I said that it was so important that I said I'd pay for it. You know, because we got a little bit of a nest egg, and sure it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you
yeah.
pass away.
All right, folks, we'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice.
Thank you.
That's a nice shake. I'm Dr. R. Deuk Machen here at the Deuk Spine Institute with one of my patients who's traveled from North Carolina because he had some herniated discs in his lower back and he was having problems with the back. What kind of problems brought you to Deuk Spine Institute?
Dr. Deuk, it was severe pain that I had never experienced before, and pain that scared me so much that I thought it was going to change the way I lived. I've got a family and I'm active, and it literally scared me to death. And as I'm talking to you right now, the hair standing up on my neck, the pain that I was suffering and where I thought I was, I didn't think there was going to be an answer.
And you were pretty much bedridden. You couldn't get out of bed. I remember you showed up here in a wheelchair because any standing was causing sciatic type pain in your leg.
Yeah, there was no doubt. And that's not an over exaggeration where I could maybe get up, like stand for 15, 20 seconds so I could get to the bathroom to go urinate, for instance. But then when I got there, I had to lay on the floor so I could rest up a little bit so I could stand with pain to even be able to try to urinate. And this went on for 2.5 weeks. It was absolutely brutal. And there was no respite. Pain that I had in the past, I could find some position where there was some respite from the pain, and there was nothing.
So your wife is a physician. Was she able to fix your back problem for you?
I wish. No, I mean, she consoled me. And in the town that we come from, we know a lot of folks. And to be absolutely honest, we just weren't getting a lot of help. And like I said, we know a lot of folks, and it was prolonged, and we were talking about pain management and all that, and that's just not for me. And like I said, I was scared to death.
The problem with pain management, unfortunately, is that it doesn't fix the issue when you have a herniated disc and back pain from a herniated disc, because you need surgery on that disc to repair it. That's what the Deuk laser disc repair did. And you can actually see here that we went into his disc with the endoscope and we were cleaning out the herniation with the laser. And the laser actually makes a huge difference. People say, oh, lasers, they're not used in spine surgery, but they are. And they're very, very powerful tools and very precise. So we were able to clean out your discs, remove the herniation. And how do you feel today?
I feel great. I mean, it's probably, I mean, I know I'm on camera right here, but I literally could not walk into the office yesterday. And I mean, you're gonna see my shorts and everything, you'll have to edit, whatever, but I'm able to walk.
That's awesome.
And I'm just, it wasn't even close. I was actually, and I don't know if you can tell from the...
Hi there, I'm Dr. Deuk, and we've just completed a Deuk laser disc repair on a patient from Vancouver, Canada, who flew down here to Florida to have 2 herniated discs in his neck fixed because he did not want fusion. He did not want artificial discs. Did not want metal in his neck, and there's no reason to have metal put in your neck anymore. Degenerated discs, herniated discs, bulging discs, protruding discs, ruptured discs, slip discs, protruded discs, extruded discs, all of those conditions involving the disc, which are a very common cause of neck pain and arm symptoms. And he did not want to have an invasive surgery done, so he chose the endoscopic Deuk laser disc repair. You can see from the surgery, the incision is quite literally 4 millimeters. It's a tiny little cut, and I use a little tube to go into the disc and basically get to the back where I use a laser to clean out the herniation in the back of the disc. You can see if this is a disc, this is the back where the herniation is, and I zap all that away and remove the herniation stuck in the tear. That's going to allow the disc to heal naturally, and that's what people want. They want a natural solution to their disc problem. There's another model here. As a matter of fact, we were talking about Jerome Fryer, and Jerome is the owner of a company in Canada that produces literally the best spine models in the world. And I'm going to show you a comparison just to give you an idea. This is one of the sawbones models we use. It's not very descriptive or anatomically correct. Let me just show you the difference between the typical model made out of plastic and some rubber, and then a Jerome Special. And I forgot the name. What's Jerome's company's name?
Dynamic Disc Designs Corporation.
Of course, Dynamic Disc Design. I've known about Dynamic Disc Design for about 15, 16 years. Jerome and I have known each other, worked together. Look at the detail here. And I don't get any commissions on any of these sales, by the way. But number one, look at the nerve roots. They're pretty much anatomically correct. He's got the gray and white rami communicantes. He's got branches coming off in the foramen, like the medial branch of the dorsal ramus. Look inside the bone. You can actually see blood vessels. You can see the back of the disc there. There's actually a tear, and you can see the inflammation and the little nerves in there. That may be the Deuk spine model, as a matter of fact, the one that I helped them design. All right, now look at the cervical spine. You've got bones, you've got a disc between them, and just look inside there. You can actually see a tear in the back of the disc. Can you guys see that?
Yeah.
Right there. Now watch what happens when people lift things. their bones squeeze down, and this jelly comes out. You see that? That's the herniation right there, coming out. And guess what it's hitting? It's hitting the spinal cord, because that's what's right behind the disc. That's what we fixed today. All right, let's take the first question.
All right. First question comes from Julie Bruling on Facebook.
Hi, Julie.
And she said, I have a titanium plate at my C6-C7. One of my screws have broken and it is causing headaches. Can you tell me, is there anything that can be done?
So Julie has a titanium plate and a broken screw. She thinks that the screw is causing headaches, wants to know if anything can be done. First of all, obviously the disclaimers, I haven't seen your images. I don't know exactly what's going on. I would never give you a 100% answer unless I could see you, see the images. But here's my initial thoughts. I have never seen a broken screw cause headaches, ever. I've seen some broken screws in my time, 26 years of doing this. I've probably seen 100 patients with broken screws. They don't get headaches. What broken screws can do is cause the fusion not to take. And even if you do get a broken screw, most of the time the fusion still takes. The whole purpose of the screw and the plate is to hold the bones together so they fuse. So many times, even with broken screws or loose screws, fusion still happens. And if the fusion happens, you don't need to do anything with the screw. I think your headaches are coming from something else. I would probably, if I had to put money on something, I would say there's another disc bulge or herniation, either above your fusion or below it, probably above it at C5-6. And I bet you that's what's causing your headaches. The best thing you can do, or anybody out there can do, get your MRI uploaded to Deuk Spine. Go to www.deukspine.com. We're going to type it right now in the address bar on YouTube, Facebook, www.deukspine.com. Just type it in the response.
Oh, sorry. I would have copied this.
And if you go to deukspine.com, you can actually see there's a free MRI review link. The other link you could use is mri.deukspine.com, mri.deukspine.com. And that gives you the ability to answer a few questions and upload your MRI images and your report. We need both the images and the report, and then I'll meet with you virtually and I'll show you exactly why you're having headaches. But I don't think it's a broken screw. So yes, something can be done for your headaches. I just don't believe it's a broken screw causing it. I'm 99% sure it's not the broken screw. Next question.
Next question comes from Becky Heidorf on Facebook.
Hello, Becky, on Facebook.
And she asked, is it possible, or have you had any patients who would need this procedure along with a foraminotomy?
So Becky's asking if you would ever need to do this procedure along with a foraminotomy. So let me show you what a foraminotomy is. It's a great question, Becky. Thank you for asking it. Let's take the cheap model. Sorry, Jerome, but I can't squeeze the disc out with my hand right now. The foramen is basically this. Let me just use the cervical model. All right, the foramen, this is the back of the spine. This is the front of the spine. The foramen is this hole right here where the toothpick is. Can you all see that? It's where the toothpick's coming out, okay? The nerve exits the spine through the foramen. So a herniated disc right here can push back on the nerve as it exits the foramen. And that's exactly what you're seeing right here. So the herniated disc will push on the nerve as it exits the foramen. That herniation causes narrowing of the hole where the nerve comes out. So naturally, because the nerve's coming out, the nerve's still there, it's getting narrowed, and the narrowing pinches the nerve and causes nerve symptoms. So can I do a foraminotomy, which is opening up the foramen, getting the pressure off the nerve? Can I do that at the same time as the Deuk laser disc repair? The answer is yes. A foraminotomy is actually part of the Deuk laser disc repair. And if you watched me, I was in there in the foramen removing herniations out of the foramen. So foraminotomy is naturally part of the Deuk laser disc repair already. Good question.
I believe that is it.
That's all our questions. We'll be back in another 45 minutes with another cervical Deuk laser disc repair. This gentleman comes to us from Fort Myers, Florida, and he showed up yesterday. He's been offered a fusion. He did not want the fusion ACDF done in Fort Myers, so he ran over to here to Brevard County, 4 hours away, came with his brother, and he said, do your laser surgery on me tomorrow. So here we are doing his surgery in one day.